has to come. So we fought and put it there before it got onto the payroll. But otherwise, they were calling them clinical assistants before the nurse assistant name appeared on the payroll. These are some failed policy initiatives that can also draw people out or into the system. At the meso level, these are the professional areas. We are interested in career prospects. We are interested in good working environment. Poor career development is a no-go area. And poor job satisfaction also creates or serves as a push for people to leave the system. Unemployment. This morning I heard one doctor saying she is still unemployed, waiting for posting. Charlie, in the past we didn't have this. You finish within 2 months, you have your posting. If you don't go within that time, we are even taking away your yes, the clearance. We'll take it away and give it to somebody else, because at that time we could swap and give your clearance to somebody else. So, but this time you stay at home too. Even the nurses are doing about 4 years at home. Yes. And why would they not look for opportunities elsewhere? So these are also policies that are fueling the migration. Professional satisfaction, if it's not there, it will push people out. Even difficult licensing exam. You know, the Medical and Dental Council exam, is a barrier for a lot of people. And so that is also pushing some people who have trained elsewhere into this country out into other areas where they can have it a little easier registering. The other aspect is difficult exams in the receiving country, where the systems are not too... Okay. You should have told me earlier that I had this. Okay, then we'll do... Right. He says I should hurry. So, in the micro area, family ties, and the family ties work two ways. When you have family ties in the receiving countries, it can also propel you to go. It's a push factor for you locally, and it's a pull factor externally for you. But when you start building family locally, it ties you down here. So the family tie here, that one has ropes. It ties you down here. The other one takes you away. Better quality life, peer pressure. When your colleagues have gone, they are also pushing you. Some of us have resisted, but sometimes it doesn't work. And the peer pressure can be even from pressure from family, that everybody is going, why are you here? And age can be a factor. Advancing age is not a good recipe to go. It's not good once you are old. If you are young, adventure is there, and you can do better in that. Patriotism, and I know later you'll be talking about patriotism. Patriotism is also a good element. When somebody is patriotic, whether the system is, however it is, he will stay and he will support the system. The cost of migration is also an issue. How much the ticket is. At the time, it was not an issue when we were taking ADHA. There was a time we had an allowance called additional duty allowance, and it was calculated in hours, and it was quite good. Some people built houses out of that. There's a house in Kufobia, it's called ADHA house. It belongs to a doctor. He built a house out of the ADHA. And it was allowing people to buy the ticket and go straight like that. So even though it was retaining some people, it also fueled the exit of a few others. And at that time it was good. You know, my friend and classmate in Siansari was the chief executive of the Tamale Teaching Hospital at that time. He said his doctors came to him and pledged that because of the ADHA, they are going to work without break. But it didn't last. After a few months, they wanted more. And those who have already or spent some time abroad already are also more inclined to go back in there. The men tend to go, the women tend to stay. And extended family financial needs can also be a big driver when they are always on you, asking, this warfare has died, we need money to go and bury him. Then you are there, you say, no, if I don't go, these people will finish me. Okay, so these are some of the issues. And once it's there, you know, these economic challenges, and who says Ghana is out of the economic woods now? Political instability, that, thank God we are stable. But there are issues that are still there. In those days, because of the military government and the rest, a lot of us left and went, you know, just to our neighboring Nigeria. Others also went to South Africa, and those were the two key areas. Then from there to Canada, to UK and the US, and later some to Australia. Limited professional growth is also a big issue in this area, and that looks at the personal level, and it creates a lot of problems within the system. Next slide, please. These are, no, next slide. Yes, these are some of the strategies that were adopted. A car hire purchase where they bought cars mainly for doctors initially, and then later for other health workers as well. But the people who got the cars, even though they paid by installments, a lot of them left still. The former, Deputy Director General of the Brecho, Dr. Samaba, your board chairman, he got a car, but he left. My own colleague, who was Director HR, and I was his deputy, Dovlo, also got a car. A few months later, he left. And I was making a presentation in Afro, WHO Afro, and he was chairing the session. And so I said, the chairman is also in this group. He took a car. I can mention the car number and the color. He took, but he's not there now. So, and I haven't got a car, but I'm still in the system. And now we are signing bonds. We are looking at other costs and retrieving if people are not. There was also a lot of professional group agitation for improvement in conditions of service, and also reforming the postgraduate training system. In the past, it was terrible. People stayed in the postgraduate training program for 10 years and not getting anything out. It is better these days. I think the teachers are doing well. I think you should clap for them. I've talked about the increased remuneration. After a while, this ADHA, we saw that it was going to collapse the government. So we advised government, if you convert it to salary, it will help. So we got a consultant from the UK to come and help us follow the UK system and create a health sector salary scale. And that is called the HSS. But when the Ghana Universal Salary Scale came, I advised GMA, they were moving too fast to go into GUSS. And they did. And when they were going, other people were looking at the HSS, that the doctors, the salary is too good. We want to be like the doctors. And we too were going. And we didn't know where we were going. So we got something, but it wasn't good. I told them, let's wait. When they all get it, police, they got about 2-3 times what they were getting. We didn't get up to double. Like if they had all gotten, then we'll say that, okay, when they were there, we were here. Now they have come to meet us, so we also want to go where we belong. That's how to do salary negotiations, but we missed it. And we jumped too early, and the people were happy to bring us in. Deprived area incentive scheme. These days, we are not hearing much about that, but in the past, it was a big issue. It was a policy direction we dreamt of and brought in and fought, and one day, the minister went somewhere and said, this is what we intend to do, that those in deprived areas will get, and then the press took it up. This is the best minister. Then he came to the office on Monday. He said, hey, I didn't hear I said, wait, let's work out the details because it is. He told the accountant that they say the thing is good. I've been made best minister of the month. Send the money. They avoided Ghana Health Service, sent the monies to the district assemblies. Some of them used it in building markets, finishing market projects. Because there were no details as to how to distribute the money to the health workers. Some also shared it to all health workers. Meanwhile, it was for certain essential groups. So it was destroyed. And after that, it didn't work again. It didn't work. So some of the failed policies, the technocrats who drew it knew how to do it, but the politician thought we were wasting time and he needed to move fast and he destroyed it. Postgraduate training. In the past, we did everything virtually in Nigeria. Even updates, we would go to Nigeria and do it. But we gradually localized it. And that was also part to keep people within. Then the establishment of the Ghana College of Physicians and Surgeons. It wasn't easy. There were our own colleagues who opposed it, that it was going to destroy the West African College. And we had to resist that. And now I think it is helping the West African College, right? We've also gone into international recruitment arrangements, partnerships. First with Jamaica, we sent nurses. When they came, I think only one out of the 30 or so that went stayed in Ghana. You know, once you register in Jamaica, you have reciprocal registration in the UK. So they didn't need to take any exam. They went to and showed that they had been registered in Jamaica straight into the UK system. So they came, took their husbands, and then they went to UK. Then others came from the UK. We signed agreements with them. And then we said, bring us reports about how these people are doing. After some time, we'll bring you another group. And when they went, they wrote to me that the people are free and I have no control over them. When you were signing, they were signing. When they went, their mouths changed and everything. So we lost in that. Now we have sent some people to Barbados. And we made a lot of noise that we have extra nurses to send out. But before we could say Jack, WHO came and said, your figures do not support a sending country. We still have deficits, so you cannot. So now we have to cancel. We were already going to sign with the UK and send people in plane loads to the UK. So now they have. But the Philippines have a very good example. They have a good example. And if we were to follow the Philippines example, the amount of money, the remittances they get is about the highest. And because of that, when their return workers are coming, they have, in the airport, they have a special line that they follow. They don't queue. They have priority. Like first class passengers, they go through another gate because it gives them money. Other retention strategies, the 2-year housemanship you've talked about was one of it. It was something we wanted, but we said no, the people are not rounded enough. They need to get additional training. But we wanted to keep you here at this additional year. Some of you will get married, will change your mind. Some of you yeah, so some of you too will develop other interests. Yes, other interests. so that's the 2-year housemanship program. But then the rural service. In the past, yes, it was required, but at a point we suspended it because we wanted the postgraduate system also to go, and we needed people into there. So immediately after house job, or people who were even about completing house job were admitted to the exam and interviewed in readiness to go, because we needed people a lot into the system to front load it and let it go. There is a lot of push that African countries or West African countries must work towards a 15% of their budget going into the health sector. We haven't achieved that. We have gone up to 12% before. Now, if you ask me, I think we have gone down to about 7%. We have never achieved it. If we do that, we may get something more in our next. But the trends are even worsening because there is increasing globalization and increased mobility of our health workers. There's also training at high level, so people are able to go out and be part of the systems in the external environment. Our economic difficulties are persistent. Even some subspecialty training cannot be done here. You need to go out, and if you don't take care, you might not come back. This is, next slide, sorry, next slide. This is a table depicting nurses, those asking for verification data for external agencies. Can you look at 2018, only 564 asked for verification to go, to show to employers abroad. 2020, 2,000. 100. 2021, this COVID time, 5,124. 2022, 10,000. 23, 12,000 plus. These are people intending to travel, and it's a proxy for us to know who are making it out there. Not all the 12 may go, but maybe 10,000 would have left. And it is a pointer that the brain drain is worsening. It is not getting better, or it is not stabilizing. But I think we need to look forward at improving compensation and our working conditions, looking at things that will retain people within, and also bridge the disparities between the underserved areas and the urban areas in Ghana. And then look at international partnerships which can be positive. Yes, we may not have all the nurses we need, but we are training nurses at a certain level that we can trade with external. Those, when they came from Barbados, they were looking for critical care nurses. Yes, they want the high grade who can work in emergencies, who can work in theaters, can work in various places that will yield them a lot more revenue. So those are the things we need to concentrate on and do it well, and do it to the standards that they have, so that when they are going, it is easier, and when they are coming back, they can come back also in the return migration with resources that can be, and also experience that can be implanted in our system. But there is also another opportunity where you agree with the receiving country that, okay, bring teachers into some of our systems here, or come and build schools to train for you. I think that anybody would agree that if the British have come and developed the school and say they are training people to take to the UK, that the WHO cannot stop them. It will be something that, because SOS is there, they are feeding British universities with their A-level and other passes. Again, next slide. Next. Right. So we need to look at competitive compensation in our policy interventions, enhancing the working conditions, looking at opportunities for career advancement, and also allowing, next slide, strengthening the local training programs so that there's more investment in there. We can train more people and prepare to send some elsewhere. Next slide. Yes, the issue of managed migration is important, that the country takes specific actions to build capacity in a certain area and then exchanges these people so that we can get remittances and all that. So there are partnerships, establishing bilateral agreements with countries so that we can benefit from them, and then they also benefit. Then retention initiatives locally, reintegration. There was a time when even GTZ and GIZ and some other were running programs, and DED were running programs where Ghanaian doctors in Germany were being supported to come and set up clinics and facilities in Ghana so that they could be, they could stay in here. I think they tell me it's still available for certain people. And I think that is also a way of helping. But I can't see the British doing that. I can't see them doing that. Next slide. getting the return migration into work, so that people who are currently out there, before, I think a few years ago, we were in discussion with the Ghana Physicians and Surgeons Foundation of North America to use UGMC as their hub, that on vacation they can come, spend about 10 days there, offer service, teach, and then they can go back. And I pray that the systems, because they came to look at the systems, they were very happy with the systems because it matched any system in the US area. Next slide. So my prayer is that all stakeholders, including you and even the students, will work together so that we can address this brain drain crisis. We must work together so that we give the best to our Ghanaian community. Thank you very much.